Okay, last two topics for your final exam. Let's start with the anatomy of the liver. We've all seen liver tissue, correct? You've seen it in supermarkets. Who has not seen a real liver tissue? Okay, thank you. So everybody knows what it looks like. What color is it? Dark red. Yeah. Okay, so the one you've seen, cherry brown's probably from the supermarket, yeah? But a living liver is actually very red. Is it soft or hard? Soft and squishy, yeah? Okay. So this is what our liver looks like. So here we have the liver. So let's say this is me. So that means there's a stomach here, correct? Stomach here, esophagus over there, and small intestines will be over here, and large bowels will be here, kidneys in the back, bladder, uterus somewhere here, prostate, and then above here is the diaphragm, and then up there the heart, right lung, left lung. So the circulation here is the portal vein. It's not shown in this figure, but we will be shown later as we go into ascites. Okay. This is what a hepatocyte looks like. These are the liver cells. So you have millions of them. Let's review the functions of the liver. These functions will be reduced or absent depending on the extent of liver disease. For the final exam, we will only be using one exemplar or one example, which is liver cirrhosis. We choose that because that's the one disorder that will manifest all the disorders we will see in this chapter. Meaning you can find all of them in one disease condition, in one liver disease condition, in cirrhosis. So let's review again the functions of the liver, because once you know what your liver does, then these are the functions that we will miss once the patient develops liver cirrhosis. Any questions so far? So first is glucose metabolism. This is in the form of glycogen. Whatever excess food we eat, because we can never eat just enough, or either we eat too much or too little, the rest of it will be stored as either fat, and some will be stored as glycogen. Glycogen is our emergency glucose store, meaning during periods of starvation, let's say you're trapped in a subway train or you're sleeping 12, 14 hours straight. You're kept alive by glycogen. So your liver will convert this with the help of glucagon. It will be turned back to glucose, and this is what we live on during starvation periods. Ammonia conversion. What is ammonia? This is a waste product from protein metabolism. So after this is destroyed by the liver, this is converted into urea and then excreted through the urine. Okay, so part of the BUN and creatinine. But it's in its raw form, ammonia is directly produced after protein metabolism. And only liver converts ammonia to urea. So no liver function, no ammonia excretion. You follow? Okay. So what can ammonia do? This compound can damage your brain. This will cause severe metabolic acidosis, causing encephalopathy. The patient will have altered mental status and eventually brain damage, and they'll go into a coma, then die. Protein metabolism is probably one of the most important functions of our liver. So it synthesizes protein. Protein is needed all over the body. We need it to make clotting factors. We need it to maintain tissue, repair damage, and build tissues, right? We need protein. We also need protein in the plasma. And as long as we have normal levels of protein in the plasma, then we will be able to maintain normal blood volume to achieve homeostasis. Okay, meaning if you have normal amounts of albumin, then water in the plasma will stay in the bloodstream. So everything is good. Blood pressure is good. Fluid and electrolytes are in balance. However, take away protein, then we will have a disastrous shifting of fluids, because without enough protein in the bloodstream, plasma cannot hold water. Water, as a result, will leave the bloodstream, will leave the capillaries, leave the arteries, leave the veins in a process called third spacing, simply because there is an imbalance in the concentration between the three fluid compartments. So all of a sudden, your plasma volume, meaning your intravascular volume, has lesser concentration now compared to the interstitial, compared to the intracellular compartments. So as a result, what will osmosis do? Water will go from an area of lower concentration to an area of higher. So water will leave the vascular compartment. It will leave the capillaries, leave the artery, leave the veins, and go into the interstitial or even the intracellular compartments. So once liver function is gone, we will have clotting problems because we will not be able to create clotting factors. We will not be able to hold water in the plasma. So there will be edema, or what we call third spacing, dropping blood pressure and causing fluid buildup known as ascites in the abdomen, specifically the peritoneal cavity, and also in the lower extremities. Fat metabolism, believe it or not, we do need fat, correct? Okay. So the fat, of course, is one of our emergency fuel sources. Okay, so no liver function, then we cannot form fat. Okay, we cannot metabolize fat. That may not seem very interesting to you because you want to get rid of fat, but this is actually vital for human survival. Vitamin and iron storage. So when the patients have liver cirrhosis or liver damage, they will be given vitamins and minerals, because can they store it? Not anymore. So we'll have to give it daily. Bile formation. Bile is responsible for fat metabolism or fat digestion. Without bile, then can we digest fat? Can we absorb it? No. So there will be abnormal excretion of fat as a result. It will be present in the feces, causing really stinky feces and weird looking feces as well. So it look gray or pale and then very, very smelly. Plus, this will also prevent us from absorbing, fat soluble vitamins as a result, making us even more vitamin and mineral deficient. Bilirubin excretion. So red blood cells eventually die, correct? So they have to be recycled. So one of the waste products after we destroy red blood cells, after they die, is bilirubin. So inability to excrete this would mean the bilirubin will stay in the body, manifested as jaundice in the skin and in the sclera of the eyes. Drug metabolism. All drugs, IV or oral, have to be metabolized by the liver. So therefore, this will limit our choices as well as the amount of drugs we can give the patient. Now, before I go any further, when we say cirrhosis, there are three main causes of liver cirrhosis. Think of cirrhosis as that squishy, red, soft liver is placed on a 350-degree oven or grill. Then you put it there 1 minute per side. What will happen to it 2 minutes later? It's going to shrink, right? It's going to dry up, it's going to shrink. What happens to the blood vessels, the millions of blood vessels that it contains? They're also squished and narrowed. So therefore, since all of the blood from the esophagus, so you saw the picture of the liver earlier. So this is my liver. So all the blood coming from my esophagus, my GI tract, my reproductive organs, my lower extremities, all that blood has to drain through the liver. So the last vein before it enters the inferior vena cava is the portal vein. So if my liver was cooked either by alcohol, another cause of liver cirrhosis is, besides chronic alcoholism, is hepatitis. Say I have hepatitis C or even B. Now untreated, destroyed my liver. Or if I have, let's say, biliary obstruction. So biliary obstruction can either be caused by stricture or a tumor, or maybe I'm just so obese, okay? Or a stone, for instance. So any of those three causes can destroy my liver. So as a result, what will happen to all that blood is that's supposed to pass through my liver and then enter back to my heart? There'll be congestion. So congestion, of course, will cause hydrostatic pressure to increase, causing edema. Plus, not to mention, remember the osmotic pressure because your protein is low. So now you have two forces causing edema here, causing water to leave the vasculature. So there'll be less fluid in your blood vessels, now more fluid in the interstitial spaces. Again, two reasons. One, hydrostatic pressure from the congestion because of portal hypertension. Second is the decreased osmotic pressure in the plasma because your albumin levels are low. So now, given that picture of a patient who are going to develop cirrhosis, are they alcoholics? So when they're alcoholics, do they have only a alcohol problem or will they have multiple chronic conditions? Can they have heart disease? Can they have diabetes? Can they have obesity? So since we're at alcohol, can they have other substance problems as well? Okay, so we're talking about heroin or opioids maybe. Okay, and then do they have a very good diet? Probably not, probably fast food, high cholesterol, correct? All right. So therefore, will these patients have multiple medications to treat those all other conditions? Yes. Can we still give it when this function is decreased or absent? We will be limited as to the amount and types of medications we are able to give the patient now. Any questions so far? All right, let's go now to each disorder. But before that, let's look at the assessments first and diagnostic testing. So what will we expect to be ordered once a patient comes in with liver problems? So first are these are, by the way, spider angiomas or spider veins. They will appear on the surface of the abdominal wall once you have ascites. So stretching of the skin will cause these spider veins to appear. So when you stretch that skin, of course, that will cause veins to be visible over the abdominal wall or on the skin. So most common testing will be liver function tests. We actually have a table 43 to summarize it. Before I go there, so liver biopsy is another invasive test that we commonly do. So this is in the case of, let's say, cancer is suspected. So we need a biopsy of the liver because for this procedure, because the liver is very red and therefore very vascular, correct? So what's the number one complication of this procedure? Bleeding, very good. So for table 43-1, expect bilirubin to be what? High or low? High. Expect protein to be high or low? Low. Expect PT-INR to be increased or decreased? PT and INR. Remember, the patient lacks protein to make clotting factor. So therefore, what will happen to PT-INR? Bleeding times will increase. These two liver enzymes, AST, ALT, what will happen to these? Once the liver is injured or diseased, it will actually increase. Okay. Because what is AST, ALT? These are enzymes that are released by damaged cells. So the higher the number, the more damaged cells are present. Ammonia will be high or low? High, because the liver cannot eliminate it. And therefore, it will accumulate in the bloodstream and thus it's damage in the patient's brain. Patient will eventually have altered mental status early, then eventually go unconscious and comatose. Okay. So HDL, this is your good cholesterol, LDL. So cholesterol levels are elevated in biliary obstruction and then decreased in liver disease. Other non-invasive diagnostic tests, of course, are CAT scans, MRIs, or as far as it concerns complications like esophageal varices, then endoscopies may also be done. Let's go now to manifestations. So what will we see when the patient has liver disease? Let's start with the first one, which is ascites, jaundice, sorry. So when we see yellowing of the skin, we always attribute that to what? Liver disease, okay? So something's wrong with the patient's ability to excrete bilirubin, which is the primary job of our liver. So yellowing of the skin, yellowing of the sclera of the eyes is, what will accompany this, by the way, is the urine. The urine will turn dark because bilirubin will also be excreted in the urine, along in the skin, also in the sclera of the eyes. So the urine here will turn tea colored, okay? Tea or Coca-Cola or Pepsi colored, okay? Dark. As far as the next few paragraphs go, hemolytic, hepatocellular, obstructive jaundice only pertain to, that's why they're called differently, different adjectives, because they pertain to the cause of the jaundice, meaning what led to the jaundice. However, we're not concerned about that. We're concerned about just jaundice, okay? So jaundice will look the same regardless of the cause that led to it. Okay? So we're only concerned about cirrhosis. So after jaundice, we have portal hypertension. Now, this is increased pressure throughout the portal venous system. Again, because in alcoholic cirrhosis, or also called Lennox cirrhosis, Spelling for Lennox is Laennecs, Lennox.
L-A-N.
Laennecs, Lennox, or just call it alcoholic cirrhosis. We cooked the patient's liver, so it shrunk along with the blood vessels that run through it. So therefore, can blood drain freely back into the inferior vena cava? No. So all the blood starting from your esophagus all the way to your toes will have problems draining into the portal circulation because of portal hypertension. And the other consequences of this will be mentioned in the next few manifestations. Management will be done later, different pages. Next problem is ascites. Ascites is the accumulation of 2 liters or more of fluid inside the peritoneal cavity. Where did this fluid come from again? What caused this fluid to? Okay, so because of congestion, venous congestion in the portal hypertension, in the portal circulation, pushes water out of those blood vessels. And then what's the other process? The albumin, the third spacing. Okay, so because the albumin in the plasma is so low, water leaves the bloodstreams. Okay, it will leave the blood vessel and then go into the interstitial space, including the peritoneal cavity. So 2 processes there. So technically, since the patient looks, even though the patient looks like me, okay, so a really big belly, okay, they look like 40 weeks pregnant, legs are edematous, what is their fluid status? Are they in fluid overload or fluid deficit?
Actually, that is.
Okay, let's go back. Where did this fluid come from? Did they drink 6 liters of water? Where did this water come from?
Pressure, the portal, the thirst.
Where did they come from? How did they end up in the legs? How did they end up in the peritoneal cavity? Where exactly did this water come from? Where did they come from? Yes, that's the process by which they got there, but where did they come from? Did the patient drink it? Did they have a beer bong? No. How did they get it? It came out of the blood vessels. So now what is the patient's fluid status? They're actually in hypovolemia. Okay, so that means their blood pressure can be actually low. Okay, they look like they're in fluid overload, but they're actually in deficit. Okay, so we'll be careful later when we get to the interventions, because one of the interventions to manage this ascites is diuretics. Okay, so we'll discuss later our responsibilities when administering, because there will be multiple doses of diuretics here and multiple orders as well. So we're not just giving loop or thiazide diuretics. We can also give potassium sparing diuretics here. But in whichever diuretic you're giving, since we know what will a diuretic do to the blood pressure, it will drop it. So what should you assess before administering these? Okay, make sure the blood pressure will be above 100. Okay, because if you give it above 100, what will happen after administration? Blood pressure will drop to the 90s, right? Which is still normal, right? But if it's already in the 90s and then you administer an diuretic, what will happen to it? It will now go into the 80s or even 70s. Okay, so what's our threshold again? Above 100. So what's in this acidic fluid? So what is inside? What does this fluid in the peritoneal cavity contain? It is actually mostly albumin. Okay, so it's albumin rich. Yeah, it's a lot of water, but there's a lot of albumin in it. That's why it's collecting there because of third spacing. Yeah, it's going there, okay, because of the low albumin. So it can reach 20 liters or even higher. Ascites, as mentioned here, again, this is not exclusive in liver disease. Okay, you may see ascites in other conditions as well because there are other conditions that can trigger third spacing as well. Number one example is cancer, especially metastatic cancers. It can lead to low albumin as well and can cause third spacing, which appears as if the patient has liver disease. So manifestations, big belly, edematous extremities, rapid weight gain. So the accumulation of this fluid will be hours, not days. Okay. So let's say the patient comes in today, we don't do any interventions. 2 days later, this patient is now short of breath. What type of respiratory failure is this? When you have a patient with a belly the size of 40 weeks gestation. So what's it doing? What's it doing now? How do you describe the abdominal cavity pressure? Very high. So it's pressing against the diaphragm, correct? So what type of respiratory failure will result? Is it going to be hypoxemic or ventilatory respiratory failure? Ventilatory, because the diaphragm cannot contract down. And as already mentioned in the picture earlier, there will be striae, there's stretch marks and distended veins all over the abdominal wall. Hernias can also form, especially if the patient does not comply with the activity restrictions. One of the interventions for ascites is bed rest. If this patient, for example, is a laborer, let's say this patient is a construction worker, okay, an alcoholic construction worker, he has to keep working to feed his family. He does not want to lose his job because another person will quickly fill that position. So he continues working with ascites. Can he develop hernias? He keeps carrying 50, 80-pound cement bags. Okay. All right. So how do we diagnose? Of course, we have to do ultrasound or CT scan. And if possible, we need a sample of the fluid. How do we manage the ascites? So go back again to how did this form again? What were the two processes involved? Hydrostatic pressure because of congestion of the blood vessels. Next is the correct because of low albumin. Okay. Now the quickest way to do this is to drain it. However, early on we can try most conservative. Let's try nutritional therapy. Since this is now fluid accumulating in the abdomen, what type of diet will we provide? Okay, low or high sodium? Okay, there'll be low sodium. As far as potassium, it will depend on the patient's potassium level, but definitely low sodium. And we already learned about salt substitutes, yeah, in chronic kidney disease as well as in heart failure. Okay, so be careful if the patient opts for salt substitutes. Remember, is this patient only having liver disorder? No, more likely this patient will have other chronic conditions as well. Okay, because of how they ended up like this in the first place. So 2-gram sodium diet is ideal. Let's now go to drug therapy. Oh, speaking of which, your final exam has about under 40. Okay, so it's almost 40 drug questions. I will send you the list of drugs, so at least you know what to study.
Thank you. You're so sweet.
No, I meant I'm thinking about sending you a list of those medications. Okay. Okay, the most successful way to non-invasive way to get rid of ascites is diuretics. I already explained what's your number one consideration before administering it. Okay, check blood pressure. Make sure again the systolic blood pressure is above 100. Okay, so typically we use multiple. So it could be thiazide or loop or even spironolactone. The goal for fluid removal is no more than 1 liter per day or 1 kilogram or 2.2 pounds per day. Are we clear? So we do not remove. If we're using diuretics, okay, so for if it's diuretics, our goal is a fluid loss of 1 liter per day or 1 kilogram or 2.2 pounds. Now it's different when we drain it. Okay, that's a different story because the problem with diuretics is, are we just losing fluids? No, we're losing electrolytes as well. So that's why we're limiting the fluid loss through drugs, through diuretics. Okay. So again, these are the possible complications. That's why we try to set a goal of 1 liter per day. There will be serious fluid and electrolyte imbalances as a result. Okay, so now we've created other problems as well. Plus, once the patient has fluid and electrolyte problems now, that will worsen the encephalopathy. Okay, so this will facilitate or promote the development of brain damage. Activity is bed rest. These patients are volume depleted, they have shortness of breath, they cannot tolerate activity, and plus the liver needs to heal, so they need bed rest. I will talk about proteins a little bit later. Okay, for the invasive intervention is a procedure called paracentesis. So this is the removal of acidic fluid from the peritoneal cavity through using a needle. In this country and other developed countries, we do this procedure under ultrasound guidance, meaning before the doctor inserts the needle, ultrasound of the abdomen will be ordered. The purpose, the indication would be to map the peritoneal cavity. Now, because we have several organs in there, right? We have stomach, small intestines, spleen, liver, kidneys are also there. You have your uterus there, the bladder, large intestines. So it's all jumbled in there, correct? So is there one spot that all this fluid will gather? No, they will be trapped everywhere. So the purpose of the ultrasound guidance is to map where is the largest pocket of fluid, because we can't insert multiple needles. We're only going to insert one. So we want to maximize the drainage of that insertion site. So hence the ultrasound mapping. So once the tech finishes the ultrasound, they will draw with a Sharpie, okay, marking the areas of the abdomen with the largest pockets. And since we're only sticking one area, the patient will be asked to move from side to side to promote drainage of to mobilize the fluid, okay, so that we drain as much as we can. During the procedure, patient's blood pressure will be monitored frequently. This is to determine when to stop draining. We can drain up to 6 liters for this procedure. The limitation, of course, is the patient's tolerance. So if the blood pressure is dropping too fast, of course, we have to stop. Okay, we cannot, although the goal again is to drain the maximum amount, we are limited by the patient's tolerance of the procedure. Because even though, yes, this fluid is not inside the patient's cell, it's not inside the patient's bloodstream, it's somewhere in between. However, it's still inside the patient's body though. So it will still affect fluid balance overall, because once you remove that fluid, then fluid will shift again between the intravascular and intracellular compartments. And one other important thing is, so where is the map going to be likely? Is it going to be above or below the abdomen? Where's the ultrasound tech going to likely mark fluid accumulation? Will it be somewhere here
No.
or somewhere here? Right here. So if it happens to be here, what organ is closest there that happens to contain fluid, which is the same fluid as the ascitic fluid, the bladder? So most important thing you do before sending the patient is ask the patient to void. They can't void, then ask for an order for straight cath. Okay, but very important is to empty the bladder, because otherwise the doctor sticks the bladder and water comes out, looks like acidic fluid, okay, but when in fact it was the bladder that we just perforated. Now we've created a different problem. So 5 to 6 is permitted to be drained. Usually no more than that. That's just way too much. Will cause rapid fluid shifts as well as severe hypotension. A sample is automatically sent to the lab. If there's no order, ask for one, because we need to, because what's likely to grow there if the fluid sits there for several hours or several days? Usually organisms will start growing. So we automatically send it so that we proactively treat the patient for peritonitis. Okay, so if that thing grows any organisms, that means the patient is starting to develop peritonitis. Remember, that will lead to sepsis. Then not only this, so this will be coupled, of course, with with nutritional therapy, meaning low sodium diet. Now, in the case wherein the patient's liver disease is so advanced that the patient's ascites is coming back nonstop. For example, so if I have stage 4, which is basically end stage liver disease, I have ascites today. So I come to the ER because I have the symptoms, can't do anything, okay, I can't breathe, I'm miserable. I come to the ER, doctor taps me, okay, performs a paracentesis, I go home. 2 days later, I come back, same or even bigger abdominal cavity, okay? So same distension, okay, taps me again, I go home. 2 days later, I come back again. So since I'm end stage, I'm going to die eventually. What will be a better way to manage this? That way I have a better quality of life and die more peacefully and not be miserable and don't have to keep going to the ER when I should be spending that time with my family, spending my last days or last months with my family. It's going to be TIPS. Okay, so there's a picture here. What is TIPS? Stands for transjugular intrahepatic photosystemic shunt. Now, what's the purpose of this? So this is to manage ascites, especially if the ascites in this case is refractory. Would you agree? Refractory means unresponsive to treatment, okay? Meaning persists besides treatment. Meaning I already did nutritional therapy, I'm already doing diuretics. It's still accumulating. Okay, so that's refractory ascites, which is usually present in end stage. So again, this is not a first line. Here it tells you clearly here. TIPS is a second line therapy for ascites that continues to occur despite medical management, which is again present in which stage? Okay, end stage liver disease already. There's a big however here. Because, let me explain why. The liver and the hepatocytes, the functional unit, functional cells of the liver are very resilient. Meaning, so let's say this is 100% liver function. If I only have 10% left or less, meaning the hepatocytes that are still functional are scattered all over here, but overall, only 10% of them are left or even less. It's better than zero, correct? Will you take 10% or none at all? I'll take 10%. So that means, remember all those functions of the liver: glucose metabolism, fat metabolism, protein metabolism, drug metabolism, everything. Okay, ammonia removal. Okay. So when blood flows through here, so it will flow throughout the liver tissue, and then go back here, and then enter the arteria vena cava, okay, back to the heart. Of course, it's only 10% left, but again, it's better than zero. So therefore, there's still about 10% ammonia removal, bilirubin excretion, etc. Only 10%, but again, better than zero. In this procedure, since there's the liver has shrunk, basically, right? So that's why there's congestion here. So there's congestion here, congestion here, congestion there. So that's why I have ascites, I have edema in my legs. Hips they'll insert a shunt, basically a tube, from my neck, so from my jugular vein, then go through here, puncture through the inferior vena cava, and then into the portal circulation, bypassing the liver. So what happens is, once you have the shunt, blood will no longer flow through the liver. It will go straight into the shunt. So all the blood coming from my esophagus down to my last toes goes through the shunt and then into the inferior vena cava, bypassing the liver altogether. Will this improve ascites? Absolutely. There will be no more ascites because all the blood is moving. They go through here, straight into there. So no traffic here, no congestion to talk about. There will still be ascites, of course, because there's still low albumin. Okay, so there's still third spacing, but at least no congestion. The problem with that is, since now all the blood bypasses the liver, is there any ammonia removal at all? There is zero ammonia removal. So as a result, what is a consequence after TIPS? Higher risk of ammonia. You understand? Okay, so it will worsen the ammonia levels, increasing the risk of the development of encephalopathy. So after TIPS, the patient will be given treatment for ammonia excretion. So we'll discuss that on the next page. Other treatments, we have other shunts. However, the other shunt, let's say this one, peritoneovenous shunt, it's not really commonly done because it takes a really skilled physician to do this procedure. So there's only a few of them, and as a result, waiting times are long and it's costly. So that's rarely used. So TIPS is more popular. So nursing responsibilities, since we're not the one doing this, it will be your responsibilities before and after the procedure. After the procedure, of course, is monitoring the site, because this is a vascular procedure, so watch the site for bleeding. And then, of course, the rest of the treatment will be on the next page. esophageal varices. What is this? These are basically varicose veins. You've seen varicose veins, right? Your parents, elderly grandparents probably have, varicose veins. Okay. So let's say they work for a living. Okay. They have that. Okay. Let's say they wait tables, for instance. My mother had so many. Okay. Um, so she had, yeah, she had 14, no, 15. She had 15 pregnancies because she had one miscarriage. So that's 15 total. So you know the toll it will take on her legs, right? So she had pretty bad varicose veins. Varicose veins are usually outside, correct? Right here on your legs. These varicose veins here are inside the esophagus. So if this is your esophagus, it's not outside, it's inside where you swallow food and beverage. Okay. So imagine if you have large, tortuous, varicose veins inside your esophagus, how will it feel when you swallow hot sauce, really hot salsa, alcohol, no tequila, which you chase down, you had the tacos and then you chased it down with tequila shots. Okay. And then now you vomit as well. So when you vomit, it's not just the tequila coming out, it's also mixed with stomach acids. Okay, so what will that do to a big varicose vein? It will rupture it actually. It will rupture and bleed. Look at the statistics. 30% of compensated and 60% of decompensated cirrhosis. Now, the difference between compensated and decompensated is when we say compensated cirrhosis, meaning you're stable and your body is adjusting well. Your heart, your lungs, your kidneys are somehow adjusting to the shortcomings of your liver. Whereas when you have decompensated, meaning are they handling it well? No, the body is not doing well. So that's 90% total, correct? So only about 10% of cirrhosis patients have no esophageal varices. So that's 9 out of 10 have esophageal varices because once they develop, they will not go away. Have you ever seen varicose veins go away? No, once these veins are damaged, they're varicose, they stay like that without treatment. So you have to either sclerose them, meaning destroy them, or cut them off, right? That's the only way to get rid of varicose veins. So the number one problem here is bleeding. Okay, so upper GI bleeding. So the bleeding here, I know clotting factors are low, but the bleeding risk really is from these esophageal varices. And they can bleed anytime. Because what will cause this to rupture? Any form of straining. Remember the activities we learned last semester after eye surgery, ear surgery, or brain surgery? What are those activities that include any pushing and pulling? Okay, any pushing, lifting, right? Including sexual activity, right? Sexual activity, intercourse, constipation. What else? Bending, right? Yeah, so anything, any activity that involves pushing and pulling, okay, can cause rupture, precipitate a rupture, and patient could die. We'll do management a little bit later. So again, once formed, they do not go away. Okay, so they will extend. They can only get better. I mean, bigger. They can get worse. They will never get better. So here's the ascites teaching. They inserted it here a little bit late. This should have been on the previous page. This is already the esophageal varices page, but it's here. Please read on your own. I mean, doesn't contain anything we haven't already we haven't already discussed previously. So bleeding esophageal varices are the most life-threatening complication of liver cirrhosis. This can be the cause of death. premature death, actually. Meaning even if the patient's cirrhosis is not that advanced yet, but because they have esophageal varices, this can prematurely kill the patient. Here are the factors again. All of these cause increased intrathoracic pressure, correct? Because they're either pulling or pushing. And of course, aspirin may contribute. Hey, remember, these patients have other chronic conditions as well. So if they have heart disease, they may be on aspirin. Or if they have, let's say they're elderly, they have, I don't know, rheumatoid arthritis, they're taking NSAIDs. There you go. Okay, more factors that will precipitate bleeding. Signs and symptoms of bleeding will be, of course, we already discussed hypovolemic shock, hemorrhage. So plus we discussed this under peptic ulcer disease because there was bleeding there as well. How to diagnose the presence of esophageal varices? Well, yeah, scans. So we can use a CAT scan, but of course, it's kind of useless when we, or pointless when we do a scan, because how many cirrhotic patients have esophageal varices? 9 out of 10, correct? So therefore, they usually bypass the CAT scan, then go straight to endoscopy. Yeah, because what do we do after a scan? We're gonna do an EGD anyway. So they'll do the EGD, which is both diagnostic. We can see the varices, and we can do something right there as well. Okay, we're not gonna say, oh, we saw them. Okay, let's stop, and then we'll do another procedure next week. No, they're already there, so they'll go ahead and do any interventions. We'll mention a few interventions shortly. So endoscopy is very commonly used to diagnose and treat esophageal varices. Portal hypertension measurements, these are using either formulas or using a catheter. I really don't have any questions on this. Laboratory tests, of course, will be to diagnose the liver cirrhosis, the liver damage, and then make a conclusion. Oh, with this advanced, then definitely because the portal hypertension. Okay, so this is a safe conclusion. So if the portal hypertension measurements are really high, then is there a high chance of esophageal varices? Yes, you can bet money on that. You're a winner every time. So how do we manage varices? Well, it depends. Has it ruptured yet or not yet? For ruptured or bleeding esophageal varices, of course, these patients are critical. They go to either the OR or go to the ICU for management. And the management mentioned here is only for the varices, okay? So we already talked about blood transfusion and management of shock, chapter 11, correct? So that's there, all right? So it's not mentioned here anymore. And electrolyte replacements if needed. Drug therapy. There are 2 drugs that will be used here to slow or stop the bleeding, depending on the severity. Octreotide is a vasoconstrictor, as opposed to vasopressin, which has systemic effects. Octreotide has a limited effect. So octreotide is preferred for bleeding esophageal varices. So since they're vasoconstrictors, will it slow down or even stop the bleeding? Yes. Okay. Another is if, let's say, the bleeding is quite extensive, the patient may also receive PPIs. Remember PPIs? Okay, so in bleeding from peptic ulcer disease, so we can use PPIs. That way, if the blood vessel already, had a clot, then it will not rebleed because now you put PPIs in the patient. But if needed, especially if the patient is going to shock, then we will give vasopressin, which is a systemic vasoconstrictor. By the way, octreotide mostly is given in cirrhosis patients. However, you may see this drug in patients with, if it's bleeding cirrhosis patients, it's given IV, continuous infusion. However, if it's used for diarrhea, let's say severe diarrhea, example, people with ileostomies, really wet output, and they get dehydrated, this will be given sub-Q. Okay, because it's also a remember this vasoconstrictor, so helpful with diarrhea. Meaning it will help, slow down peristalsis.
Octreotide.
Sorry,
Octreotide.
octreotide. Yeah. All right. For acutely bleeding patients, meaning, let's say they're drunk, right? They're drunk. So the scenario I gave you, they're partying. Okay, so lots of hot stuff. Okay, and then they were taking, tequila shots. Really, messed up. Having a really good time, but then the varices ruptured. So now the patient is vomiting profusely. So vomiting blood profusely. Again, it gets worse because now the vomit, the emesis contains not only acidic foods but gastric juices plus alcohol. Okay, so now it worsens the bleeding. So now they'll use a balloon catheter. The name is Sungstaken Blakemore. So here's the tube. It's like a Foley, but it will have two balloon inflation ports. Actually, three. So you've got gastric balloon, gastric aspiration, and then esophageal balloon. So the two balloons are here and here. The location will be in the lower part of the esophagus, right here. So that's the first balloon because the varices are usually located here in this area. And then this balloon, of course, will anchor the tube so it doesn't move. So this big balloon here will compress the bleeding varices, stop the bleeding. So this will be in for at least 24 hours or as long as 36 to 72 hours. The number one concern here is because this tube is so big. It's as big as your thumb, that big, up your nose or into your mouth. So what's your number one concern there? You have a big tube obstructing your throat. Aspiration is your number one concern. So sometimes they'll pair it with endotracheal intubation. That way, we don't compromise the airway, and then we can suction, and then we can prevent aspiration at the same time. But again, the size of the tube, of course, will do other damage. Balloon tamponade. All right, so these are options to prevent aspiration. Because remember, you can't swallow with that tube obstructing your epiglottis. Okay, the throat must be clear for your epiglottis to close over your trachea and swallow. You can't swallow with this in place. So here's again the warning. Okay, watch them for aspiration. How do we prevent aspiration again? Endotracheal intubation, actually. Because no matter how you elevate the head of the bed, they can aspirate. Because remember, what will happen to secretions, the amount of secretions, whenever you have anything in your mouth, it increases. So to be safe, if the patient, especially an elderly patient, they will have to be intubated. So it's pretty effective. Okay, so stops bleeding in 90% of patients with esophageal varices bleeding. Endoscopic sclerotherapy, this is the same as repairing. I think we have a vein institute here on 6th Avenue. I see that uh, spot there wherein they treat varicose veins. So this is one of those therapies. They said they do sclerotherapy, which is basically closing the vein, destroying it. So they can do that also with the esophageal varices. Or they can do ligation, just like tying your tubes, tubal ligation. So they'll tie the blood vessels shut or cauterize them or put bands around them. For really big, they'll put a band around it, prevent it from rupturing. So that's banding. And we already talked about tips. Surgery, I won't test. Plus the questions, if you get any here, it won't be any different from chapter 16. So routine, pre and post-op care. All right, let's proceed with encephalopathy and coma. So this obviously is caused by ammonia. Now, let's go back to protein earlier. So what is hepatic encephalopathy? It is a neuropsychiatric manifestation of hepatic failure. There are different stages. This is reversible if, in the early stages. Can number one main cause of this is really ammonia. So as long as you manage ammonia levels, the patient won't have to have encephalopathy. But again, this is reversible. Okay. So yes, they will have flare-ups. Patient may have encephalopathy, be admitted. We'll manage it with aggressive lactulose administration, and then they'll be fine. After a few doses, a few days, mental status returns to baseline, and they can go home. So all of my cousins and uncles who had cirrhosis died this way. Okay, so they all look the same. So I was a small kid when that happened until I was in my, tweens. I was 13, 14. I saw them, they die. And every time I see it, they from first ones who died was my uncle Pedro, then followed by his wife, and then their children, Tote, Bebe, and then there was my other cousins, William, Benjamin. Those two are brothers. Okay? So both drunks. And Ruben, no, Ruben died from he was on dialysis, so he had a different cause of death. Yeah, he was, I think, the only sibling. No, only two siblings out of the seven. There's seven children were not alcoholics. So only Mario was about my age, maybe 3 years older than me, died from DKA. No, shock. He had a seizure, textbook DKA patient. And then, Dante also did not die. Dante is still alive. I think he's the only surviving sibling. Yeah, out of seven. No, he's my first degree cousin. Yeah. And then I have distant cousins, I just know by face. I don't know the names, but all alcoholics. So I can see, like how did Uncle Pedro die? Same, like, all bloated like that, and then, yellow, and then like this comatose, sometimes at home. Then sometimes, the cousins were brought to the hospital, died there, but they all look the same. When I see, same, same, and then I touch the feet. Why is this like this? Yeah. Okay, so how do we manage encephalopathy? Okay, so we've got this manifestation is stage 2 and up. So this is asterixis. This is flapping hand tremor. So when you ask them stage 2, ask them to raise their arms like this. So they will have involuntary flapping of the hands. This is indicating irritation of the nerves. Okay, the neurons are pretty damaged in the brain. So mostly, altered mental status, they no longer, they act crazy. There's also this stinky, it's basically poop, okay? I don't know why they call it sweet, slightly fecal, or it's poop. And these are other manifestations when you ask them to draw a star or their handwriting, again, all indicating, brain, irritation of the nerves. Management is pretty simple. Lactulose is the first line. We give lactulose. The order usually is 3 times a day. It's 60 ml 3 times a day. The goal is to produce 2 to 3 soft stools per day. 2 to 3 soft stools per day. So this is how it goes. You give one dose, they get 1 or 2 bowel movements. You give a second dose. And then if that produces any or no production, you give the third dose. Okay, what's the goal again? 2 to 3. If after 1 or 2 doses, the patient now has multiple stools, soft or even now some watery, do we need to continue? Please stop, because now you're creating another problem. Once this patient has dehydration, fluid electrolyte problems, then we're screwed. Okay, so what's the goal again for lactulose? 2 to 3. And then the evidence that it's working is of course the patient's mental status. Okay, patient's awake, alert, they know what's going on. Okay, they're fully oriented. That's how we evaluate its effectiveness. It doesn't taste good at all, tastes nasty. You can mask it with anything acceptable to them. So give it with any juice, whatever drink, okay, that can mask the taste. Because otherwise you'll have non-compliance. Nobody likes to drink this thing. Unless the patient's already confused, yeah, probably they'll take anything, but some of them are not, especially if it's working. Yeah, they won't take it. Okay, that nasty thing, no. If the patient has either a really serious aversion toward lactulose, won't take it. Other choices are non-absorbable antibiotics like neomycin, metronidazole, rifaximin. These are alternatives to lactulose. They will still do, ammonia secretion, still the same through the colon. So what's the goal again for these things? 2 to 3. Although there's no titration here though, so that doesn't really apply because if you go antibiotics, it's a flat prescription. Okay, there's no titration. Does that make sense? Unlike lactulose, where you can give 1 or give 2 or give 3. Okay, with these antibiotics, no, you give it or you don't give it. And these are your routine assessments and interventions whenever the patient has encephalopathy. Safety is number one. They don't know what they're doing. Okay, so they'll climb out of bed, crawl on the floor, injure themselves. All right, let's talk about protein. Read this bullet. Thank you, Ms. Sophia. Dietary protein. This one. Dietary protein intake should not be restricted.
They follow properly, as recommended in the past. Protein intake should be maintained at 1.2 to 1.5 grams per kilogram per day.
Okay. Go to the next one. The danger of protein.
The danger of protein malnutrition for health rates, the risk of worsening of the encephalopathy caused by increased intake.
Okay, so here's the deal. We need protein, correct? Because the patient, remember, the patient has liver disease. They need protein. Plus, protein is important again for building muscle, repairing tissue, making clotting factors. So we need protein. The restriction here, this restriction is based on the ammonia level. Okay, so meaning we don't deprive the patient of protein. We limit it based on the ammonia level. So once the ammonia levels rise, then we'll have to limit the protein, because otherwise, does it make sense? No, the encephalopathy will just keep getting worse, right? So it's really crucial that you balance it with ammonia and then adjusting the protein intake based on ammonia. Enteral feeding, because the patient is already in encephalopathy, I mean, they have mental status changes. They won't be able to follow any instructions. Okay, so they're like in stage 4 dementia. Okay, wherein they have agnosia already. They don't know what that is. They won't know what to do with it. Although it's completely reversible, as already mentioned. Be careful with any drug therapy, especially with sedatives. Remember, there's decrease or no drug metabolism here. So doesn't matter if it's oral or IV. A drug is a drug. It will be metabolized by the liver. Okay, we already talked about the nutritional management. Skip that. Okay, so the rest of these are self-explanatory. We already talked about edema and bleeding. Now, this is separate from, well, the edema, of course, is from either this third spacing or increased hydrostatic pressure, right? From venous congestion. The bleeding here is not necessarily from the varices. Remember, the patient has low clotting factors. The PT-INR are elevated or prolonged. So they are prone to bleeding nonetheless. There's also vitamin deficiencies, because remember, the liver stores vitamins and minerals. So without that function, patient is vitamin deficient. So we'll have to replace these vitamins. So usually B vitamins, okay, they'll be given that daily. Skin care, because these patients will have really dry, itchy skin. Usually we recommend warm water to wash them, and then of course keep the skin moisturized. Let's go now to viral hepatitis. There are only 3 questions on the exam. No, 3 possible questions. There are 5 viral hepatitis in this chapter. We have A, B, C, D, and E. So the 3 possible questions are: 1, how do you get it? Meaning, what is the mode of transmission? 2nd, how do you prevent it? And then 3rd will be patient teaching. I will not test you on treatment. Only on, what are they again? Mode of transmission, prevention, okay, and teaching. You can actually study them all together, because if you know the cause, then you should know how to prevent it, correct? Let's start with A. So on the next page, I hope so. Hepatitis A. So this is oral fecal, since this is called infectious hepatitis. So fecal oral route. So ingesting contaminated food and water. However, do not be too narrow with your concept, because it's anything basically you put into your mouth, correct? Now, in sexual activity, not sexual intercourse, because intercourse, of course, involves genitalia. Genitalia enters genitalia. However, in sexual activity, especially oral sex, meaning oral vaginal, oral anal, they do have microscopic fecal material, correct? No matter how you wash, you shower, there are microscopic fecal material left there. So if the partner is infected, can you contract hepatitis A and hepatitis E through sexual activity? Yes.
So A and E go both with like are the same
both ways or the same? Okay. All right, so here, hepatitis A can be transmitted during sexual activity, oral anal, or anal intercourse with multiple sex partners. Because the anus basically is like your mouth, right? I mean, it's still
The
the
anal is the mouth?
yeah, it's still a mouth. I mean, what's the difference between your mouth and your anus? They're both mucous membranes, so you can contract the organism that way. This, I mean, you understand, right? Yeah, it's just like that. So if you put contaminated stuff, something contaminated with hepatitis A, not through your mouth, but through your rectum, so yes, it enters your body too. I mean, it makes
Oh,
sense,
yeah,
right?
yeah.
Yeah.
When you put a suppository.
Yeah, so here, oral anal contact or anal intercourse. So prevention, of course, with a good thing there's a vaccine. Okay. So let's say you have you won a trip to say Mexico, and then you were warned, oh, the hotel you're going to um has been known to have, local hepatitis. It's endemic in that area. Okay, so they told you, okay, bring your own water and stuff. Um, keep in mind also, they will still advise you to get vaccinated because is everything really bottled
In the hotel? Yes.
or everywhere you go? Let's say you go out drinking.
Mhm.
Is the glass washed with
No.
bottled water? Was the ice made from bottled water? You see what I mean, right? So these things, are found everywhere basically. So you still need vaccination. Now, let's say, oh, it's too late. I'm leaving Monday. It's Friday already. There's no way I can complete the vaccination series. There's a immune globulin option. So immune globulin, this one, is the antibodies already. All right. So you'll get this, plus you'll get your first vaccine of the series. So even though the first vaccine will not protect you, you already received the antibodies. So yeah, this will provide instant protection. Okay, so you go ahead, enjoy your trip. Okay, you'll be fine.
How long did that review about it lasts just
Oh,
a-
this is not a lifetime because remember this is passive. Okay, so this is not really your body making the. So it's not lifelong. It's different from natural immunity, or acquired from vaccination. Like I said, we won't do medical management. Basically, if you have hepatitis A and E, um, it's rest. You'll be giving because it's a virus, so it will just take its course. We can give you antivirals to shorten the infectious period, but that's basically it. Bed rest, keep you alive with fluids because you'll be vomiting, diarrhea. That's what will kill you, the dehydration, and then yeah. So we'll just admit you, fluids, and then pain management. So you'll be in a lot of pain. And then education. Okay. So next time, listen to vaccination. Okay. Some of the teaching are also here. So 43, chart 43-B, you got hepatitis A, B, C. Now D isn't here because B and D are similar. In fact, you cannot get D unless you've had prior B exposure already.
You cannot get D if you have an exposure to.
No, 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 no. You cannot get D unless you have previously acquired B. Does that make sense? Okay. So if I ask you which viral hepatitis can be prevented by vaccination, which ones will you pick?
A.
What about B? B. What about D? Technically, there's no vaccine for D. However, if you receive B vaccination, are you effectively protecting against D? Yes, so answer would be A, B, and D. Okay, because there is a meaning you can't get D unless you're infected with B. Okay, meaning it's a reverse RNA. Okay? Meaning D needs B in order to enter body cells. It otherwise it's useless. You get exposed to D, there's no B, it can't infect you. Okay, impossible because it can't enter the cell without the assistance of B. Right, hepatitis B, so transmission, of course, is blood to blood, so IV drug use, unprotected sex. Here are your ways to get it: close contact, frequent exposure to body fluids, hemodialysis, IV drug use, contaminated needles, unprotected sex, especially M to M or multiple sex partners. The blood transfusion, I think it's before 1992, because that's when before that, we didn't screen for B. I think it was 1992. Um,
What about tattoo?
yeah, tattoos are listed there. So it's just like IV, IV drug use, no different. C, the same as B. So if you read B, it's the same as C. Here, C, same risk factors. And then D is pretty short because again, this will, pass you back to B. But again, how do you get this? You have to have D first. Okay, so you need B to get D.
Okay, you say the B and D, can you say B as in boy, D as in dog? 'Cause I'm confused. We need B.
It's different. B is different from D. That's just watch the video. I hope so. Then E is exactly the same as A. Previous editions of this textbook specified the countries where you could get E. This edition, no more, because basically it's everywhere. Okay, so same countries that have A also have E now because of free travel. We are very mobile now everywhere. So there's no place safe from A and E anymore.